So the topic is femoral shaft fractures. As you know, the femur is a long bone and it has many parts. It includes parts such as the head of the femur, the neck, the greater and the lesser trach, and the subtrach area. We have discussed in the previous different topics as well about the fractures around the hip, in which there were fractures around the femoral neck, greater trach, and the lesser trach area. Just 5 centimeter below the lesser trach is this is area of the lesser trach, and then starts the shaft or the diaphyseal part of the femur, which is almost the most longest part in the femur bone. And it may be classified in two forms of fractures. It could be an open fracture or it could be a closed fracture. Open fracture means in which the bone is actually either protruding out of the muscles and the skin into the air, or there is actually a small puncture wound in which there is actually protrusion and tenting of the muscles from inside out. Closed fractures, usually there is a fracture which may be associated with the femoral shaft fractures, but the bone is actually either there is no tenting or bone is not protruding out of the skin. Then it could actually the mechanism of injury is important. What matters is how much energy was transferred during the RTA. If it was a simple fall, there may be a simple transverse or oblique fracture, but usually the fracture which involves a high energy impact, for example in a car vehicle accident which may occur at a very high speed, there may be associated with highly comminuted type of fracture, if you can appreciate it over here. This is usually the result of a very high energy trauma. The bone is actually broken into multiple pieces. There may be a lot of fragments and debris and they may be associated with open fractures as well. But if it is a fall, usually a trip, especially in the case of old age, this may result in either a simple transverse or transverse oblique type of fracture, or it may be leading to a spiral fracture. Spiral fracture is one when the foot actually gets stuck in some form of a hole, or is actually stable on the ground. This usually results in that this foot is actually on the ground and the leg is actually rotating over the top of the knee. What results in, due to the weight of the body, this may result in some sort of a spiral fracture in the mid shaft of the femur. Now the types of the injury, it depends. One way of classifying femoral shaft fracture is on the basis of geometry of the fracture. Geometry could be a simple transverse fracture, that is when the force applied on this is such that this is stationary and there's a bending force is acting on the shaft of the femur. This may result in a transverse fracture. It could be a linear fracture, usually very rare, because it only occurs if in case of it's an osteoporotic bone and one side of cortex may be highly porotic and may get resulting in that sort of a fracture. Most commonly it's the transverse or the oblique type. In oblique type, there is actually a bending along with some form of rotation as well, in which there is a oblique fracture which crosses the shaft, leading to this sort of a fracture line. It could be an oblique but displaced as well. If it's slightly higher in energy and the patient had a fall from or there is an old age leading to some form of low energy RTA, this usually results in a short oblique fracture with some form of translation and eventually leading to a displaced type of a fracture, which can be appreciated in this diagram. This was the other form is actually on the spiral. The spiral fracture occurs when the foot is planted on the ground, or is actually the foot is stuck in the hole, so that the lower part of the femur is actually stationary and the other upper part is actually rotating over the lower part. This happens when the foot is stuck on the ground and patient rotates and falls due to the weight of its own body is actually acting as a force, and this rotates the proximal part, leading to this sort of a spiral fracture. This could be a green stick fracture as well, which is not usually seen in adults but more common towards the children, and this is due to the flexibility of which is naturally present in the bones of the children. That is, result that one cortex fractures and other remains intact. This could lead to a green stick type of fracture in the shaft of femur. Other is a comminuted. Comminuted is usually resulting due to very high energy or high energy impact, which may be leading to a comminuted multiple part fractures of the diaphyseal shaft of the femur. There is different classifications which are available. This could be a Winquist classification or AO classification. According to the AO classification, this bone is bone numbered as 3, and as it is the diaphyseal, so this is 3.2 point A, B or C depending upon the degree of comminution and butterfly segment. Winquist also classified on all more or less the same formula. Type 1 was actually an oblique fracture with the fragment or butterfly segment is less than 50% of the area. Type 2 was also an oblique fracture, if you can see it over here, but the problem was that this butterfly segment was more than the 50% area. In type 3, the butterfly fragment is more than 50% and is actually displaced. So this becomes type 3 injury. And type 4 is actually a comminuted fracture of the mid shaft of the femur. If you see, the classification is actually sort of telling us a tale of how much energy is actually being impacted to the fracture. This is probably all these Y1, 2 are low energy fractures, but 3 and 4 means most likely the energy was a high energy impact resulting in a shaft of femur fracture. If you see, this is the x-ray. This is actually showing. Now if you see this x-ray, almost till this area is actually the subtroch area. Then starts the shaft, and shaft is actually divided into 3 parts. There's a proximal 1/3, middle 1/3 and distal 1/3. Now this is actually showing an oblique fracture with a very small butterfly fragment, probably Winquist type 1, and this was actually treated with submuscular plating. Then there are different mechanisms as well to treat. We'll be discussing them as well. If you see, this is a mid shaft femur fracture. It looks like a spiral one. If you see it over here, it's a spiral mid shaft femur fracture. Now this is kind of a fracture which can easily be treated with a nail if it's an adult. But when we'll be discussing the different aspects of treating the femur shaft fracture, we'll be discussing in details that what are the determinants which deal with the shaft of femur fracture, what we need to look at, what is the age of the patient, opening and closing of the physis, and what different modalities which are available for the shaft of femur fractures. And this is the lower 1/3 or in the lower 1/3 shaft of the femur fracture, which appears to be highly comminuted distal 1/3 shaft of femur fracture. Now coming to the clinical features. What is usually the history and on what are the findings on examination? There is always definitive swelling and deformity of the limb with history of RTA. Usually either there is history of RTA or there is history of fall, which may result in this sort of a injury. Along with the painful leg movements, usually either there is no movement at all, or as soon as you touch the patient has a lot of severe pain in the mainly the mid-thigh region. And there may be associated other leg injuries. What you need to look at it is the shaft of femur is a long bone, and this may be associated with either head of femur fracture or neck of femur fractures, or there may be associated injuries such as pelvic or acetabular injuries as well. So you need to review the patient as per ATLS guidelines and assess what are this may be, is it isolated shaft of femur fracture or associated with other fractures or not. Then continuing with the clinical features, once we've done the primary survey, once we have stabilized the patient and there is no life-threatening emergency, then we need to move on to the secondary survey. And usually the shaft of femur fracture is mainly dealt in the secondary survey because it's not life-threatening injury most of the time. What we need to exclude at the time is neurovascular problem, that shaft of femur is it not associated with any sort of femoral artery injury. Compartment syndrome. Why? Because there is almost as high as 1 to 1.5 liters of blood loss during the shaft of femur if it's a closed shaft of femur fracture. Now, closed shaft of femur fracture would mean that if it's almost 1.5 liter of blood is in the thigh compartment, there is muscles which are also bulky at times, This means this closed compartment will be overfilled and will lead to increased compartment pressure. So in a kind of a closed compartment, this fracture, there's a very high chance of having a compartment syndrome as compared to the open injuries. But with open injuries, when you're going to be losing 1.5 liter of blood in your body out of 5 liters, this will be a hemorrhagic hypovolemic shock kind of a situation, which would be highly damaging and life-threatening for the patient. And then lower limb and pelvic injuries. First, we must make it sure is there is no associated injuries. There is always very high chances of missed injuries, and which is later on very problematic as well in terms of medical legal aspects and litigation aspects, because there is always high chances of associated neck fractures which may be undisplaced and may be missed on the radiological x-rays. So you need to be very careful in evaluating the x-rays for the femoral shaft fracture, as well as need to look at the pelvis and acetabular x-rays as well. Coming to the imaging. As per protocol, the first and foremost imaging is always the AP and the lateral view of the whole femur, which includes the hip joint as well as the knee joint. Now, this is not the adequate imaging. This is what exactly happens. You can appreciate knee joint very clearly. You can appreciate a transverse fracture of the middle third of the shaft femur, but this may be associated with a neck of femur or head of femur fracture or acetabular fracture. So if you get this kind of an x-ray, you need to order the x-ray of the femur, AP and lateral view along with the hip joint as well, because you need to look at the hip joint as well. Now this is a CT. Then sometimes CT may be required, sometimes CT is not required as well. This is sometimes this comminuted fracture, and you need to look at a 3D CT so that you know the exact anatomy of the fracture fragments. Or for example, sometimes you need Hoffa fracture. There is a Hoffa fracture, and you need to look at the CT so that you view the fracture line in the coronal plane. An MRI, which is although rarely done, but can be done sometimes just to look at what is the degree of soft tissue injury which may be associated with the shaft of femur fracture as well. Or sometimes the patient may complain of there may be an isolated stress fracture, which is, although the femur shaft is a rare place to have it, but then you probably the best diagnosis for a stress fracture is usually an MRI. Coming to the emergency treatment, what is the initial treatment? Initial treatment in all fracture is as per ATLS guidelines. You have to first look at the life-threatening injuries which may be problematic for the patient, and by that time apply the traction and splint and keep the patient immobilized for the time being. There may be associated hypovolemic shock that has to be dealt by restoring the blood volume. Patient may require a copious amount of normal saline. There may be requiring blood products as well, because these shaft of femur fractures may be bilateral or polytraumatic. The patient may have associated acetabular and pelvic fractures as well, and there will be massive loss of blood which may require blood transfusion as well. Along with analgesia, definitely it's broken bones have a lot of problems. Patient may complain of pain, and then you need to understand that whether it was an open injury or a closed injury. If it's closed injury, usually antibiotics are not required, but open injury require antibiotics as well. Coming to the definitive treatment of the isolated femoral shaft fracture. If it's isolated, we can apply traction initially as long as we are moving towards the definitive treatment. This traction could be in form of a simple splint traction, or it could be a bony traction as well in form of a pin going through the proximal tibial tubercle, or it could be going to the distal femoral area. But usually traction, which is form of a skin traction, is more than enough nowadays, because we have to go for definitive fixation, whether in form of nail or plate. Thomas splint has been utilized like from ages since World War II as well, but it's a temporary measure in which we can keep the splint and patient immobilized till the definite fixation is actually available. Coming to the spica cast. Spica casts are not actually routinely used in adults, but in the children from 6 months to 5 years of age, primary treatment or the treatment of choice is actually to apply a hip spica for the proximal 1/3 or middle 1/3 femur fracture, which is in this shape. For example, if a child is having a right femur fracture, we can apply the spica, and we can apply till up to the nipples. Why? Because we need to fix the one joint above and one joint below. Knee will be covered in the spica, and hip joint will be covered by this abdominal spica, which is covering the cast above. And then this is called as 1.5 spica, that you apply one whole spica along with the 1.5 just to give strength to this area. Once we have controlled the rotation and malalignment of the femur under the fluoroscopic guidance, then is the bracing. Usually once the fracture heals, that's physiotherapy is started, and then for the time being we can apply bracing. The bracing usually do not have a long-term results, especially it's only required in certain type of fractures. For example, if it's distal 1/3 of the femur fracture, bracing may be utilized temporarily before we go for definite fixation, which is the operative fixation. Now coming to the operative before moving on to the operative fixation, we can go for different type of tractions. Usually skeletal traction and Perkins traction is nowadays rarely utilized, because patients immediately go for surgery within 24 to 48 hours. But if it's a kind of a situation where the surgery is delayed, for example, it may be delayed as long as 10 days, 14 days for any reasons, then probably the skeletal traction is the ideal choice, so that the femur remains aligned and there is no malunion or non-union of the femur. Other form of tractions which could be utilized before the definite fixation is Russell traction, and in children it could be in form of a gallows traction. Now, gallows traction in children has been routinely utilized as a definitive form of management, in which the alignment is actually corrected and the child is placed in this sort of a thing in 1990 traction, and both the legs are actually hanging in the air. This is applied for 2 weeks to 3 weeks, and that has actually resulted in union of the femur without lot of malalignment. And this is one form of treating the children with the femur shaft fracture, especially the proximal 1/3 femoral shaft fracture in infants, especially the children with less than 1 year of age. Now coming to the definitive management. Now definitive management actually determines whether it's proximal 1/3 shaft, distal 1/3, or its middle 1/3. Usually two types of treatment are available. One is intramedullary fixation in form of nail or flexible nails, and the other form is actually the plate and screw fixation. If you see this, usually a picture of a child, because the physis is very much open and there is a spiral shaft fracture. Now if this child has an age of 5 years to 9 years, then the best option would be to go for flexible intramedullary nailing. But if this is a child is less than 5, we can go for hip spica as well. But for example, this child is around, let's see, 7 or 8 years age and is actually quite obese as well, and more than 49 kgs, then probably the best option is to go for some form of submuscular plating as well. Plating nowadays it's rarely done, but can be done, or is also an option, especially in the case of children whose physis is open. Other option is actually in form of previously the K nails were done, but nowadays the flexible titanium nail is the choice of treatment, especially in the case of children who are around 5 to 9 or 10 years of age. Now coming to the MIPO technique, which is actually minimal invasive plate osteosynthesis, which is a way of doing it is actually applying the plate with minimal incisions and using a fluoroscopic guidance to apply a long plate without much disturbing the periosteal surface of the femur. Why? Because periosteal blood supply is actually supplying the outer 1/3 of the cortex. This is like if you are applying a plate with a full technique, then you have to give a whole incision right from whole of the thigh. Instead of doing this, a small incision given on the top and a small incision given on the bottom. The plate is first subperiosteally inserted and then slid down all the way below the level of periosteum across the fracture, and then using fluoroscopic guidance 3 screws are passed below and above, and this is a bridge plate construct is actually made. This is a form of a MIPO technique, especially when there's highly comminuted and long spiral fractures in which a lot of tissue dissection is needed. It's actually a better way of avoiding a lot of periosteal stripping and leading to decreased blood supply to the cortex. And if you see a lateral view, this is how it looks like. There's 3 screws on the top, 3 bottom. The fracture is stabilized and patient can be, this actually has provides a better result because there is less periosteal stripping, less avascular area for the blood to heal, and there is actually better healing and decreased chances of non-uni and mal-uni and even infections as well. Now coming to the more choice of treatment in adults, if it's an isolated femoral shaft fracture, is it's intramedullary nailing. Now intramedullary nailing, there are multiple techniques. There could be anterograde nailing, retrograde nailing, or it could be minimal invasive technique as well. If you have this sort of a problem, or this is kind of an Winck's type 3 fracture in which there is a more than 50% butterfly and is displaced, the best way is to go for anterograde nailing. That is through the piriformis fossa. Is actually the nail is first passed back, then it's fixed with the 2 screws at the bottom and 1 trochanteric screw at the top. So what it actually controls not only the length as well as the rotation of the femur as well. Some of the pictures which are showing the antegrade intramedullary nailing, you can appreciate it. This is the fracture. This is a comminuted spiral type fracture in the mid shaft. Nail is being passed, fixed with 2 screws on top and 2 on the bottom. Different type of generation of screws and actually nails are available. There are different screws which actually they have a trochanteric entry screw which goes like this, and then there are other in which screws are actually more horizontal and going into the lesser troch. Then is a retrograde nail as well. Now retrograde nail means going through the knee. You open the knee, you don't need to open the hip, and just go through the knee and apply a nail. And first the proximal screws are inserted but the bottom, and then you have a distal screw which can be inserted over here. This is another way of doing a retrograde nail as well. Both their own advantages and disadvantages. Why actually the retrograde nails were preferred in some cases? Because the one option was there may be if associated with tibial fracture. It's a polytrauma. There is distal shaft of femur fracture along with the distal or proximal 1/3 tibial fracture. The good part is you have to fix both the fractures, so you can open the knee joint, go using a single incision and single joint, you can fix both fractures by retrograde nailing. That is where the retrograde nailing has an advantage. Why it was, there is a theoretical concept almost as well, because in adults the main blood supply is towards the head of femur is coming through the medial circumflex femoral artery, and as it ascends behind the neck, this is where the piriformis fossa is. And one most important branch actually passes just medial to the piriformis fossa, and that is where the entry point is for the anterograde nail. Anterograde nails are either through the piriformis fossa or through the greater troch. So the one way of doing it was, there was actually theoretically it is postulated that if the reaming is done too medially, this may damage the medial circumfemoral artery main branch, which may lead to eventually avascular necrosis. So it's better sometimes to, instead of going for piriformis fossa nail, either to go for greater trochanteric anterograde nail or go for retrograde nail. But there are different options available for different sort of fractures. If you see, this is almost a subtroch fracture in which a reconstructive nail has been utilized. Now this sort of unstable fractures, we can go for gamma nail, which is actually proximal femoral locking nail, or recon nail, or even a retrograde nail, depending upon surgeon's preference and type of implant which is available at that time as well. Now, if it's isolated femoral shaft fracture, some of the more diagrams, this is how the anterograde nail was done for a reverse oblique fracture, and this is probably the post-operative picture of this nail. Usually, most commonly, what's important over here is, for example, if we have this kind of a scenario in which there is a shaft of femur fracture with actually a neck of femur fracture. Now, if neck of femur is fractured, you cannot go for piriformis or gradatrochanteric entry nail because that will displace the neck fracture. So we have to go for screw fixations to save the head. Then cannulated screw is being passed, but you need to stabilize the femur fracture as well. So for that, you can go for to the neck, you can go through by the hip joint and pass these cannulated screws, and then you can open the knee joint and go for a retrograde nailing for the shaft of femur fracture. Now coming to external fixation. External fixation is more often utilized for tibia, but can be given to the femur fracture as well. Now, there are specific indications for example, there is Castillo 3B injury or 3C injury. Castillo 3B injury is when you have a massive large wound more than 10 centimeter with high energy wound, periosteal stripping, and you are unable to actually cover the wound properly so that the wound remains kind of open. So that is kind of situation we just apply the external fixator, like 2 or 3 pins on the top, 2 or 3 pins on the bottom, and stabilize the bone first, and then so that we can go for the soft tissue coverage first. Once the soft tissue coverage is available within 7 to 10 days or 14 days, then you can go for intramedullary nailing of the shaft of femur fracture. Or the option is that if, for example, there is high energy trauma and it's a Castillo 3C injury. Castillo 3C injury means it's an open fracture of the femur fracture as well as associated with femoral artery injury. If that is a situation, then you have to stabilize the bone because you need to repair the artery, and that temporary stabilization can be achieved by a form of a external fixator. Now some of the diagrams, if it's this is the kind of situation, this may be a small oblique fracture but may be associated with vascular injury. Now that is the situation, you need to apply the external fixator and repair the artery first. Although these x-rays are showing some good healing with the external fixation as well when the artery was repaired. Now if it's open femur fracture, the treatment principles are actually you have to start with the intravenous antibiotics. Most commonly, if it's Castillo classification, if it's 1 or 2 or even it's 3A, we can go for the first generation cephalosporins along with the addition of aminoglycosides. But if it's 3B and 3C and associated with farm injuries, then we have to add benzyl penicillins as well along with the aminoglycosides and first generation cephalosporins. Then first and foremost, most importantly, what determines the prognosis of an open femur fracture is how good the debridement was done initially. You may have to go for excessive debridement, apply back, and may have to redo debridement at 48 hours again, and then probably go for some form of internal fixation. But if this is sort of a situation, you have Castillo 3B and 3C type of an injury, and you have to go for debridements, maybe debridements multiple times, then probably the best way to fix the femur is by external fixator, stabilize the fracture, and once the bed is prepared, the wound is clear for the internal fixation, then we can go for some form of internal fixation, which mostly is in form of interlocking nail. That is only once all sort of debridement, necrotic tissue, or any tissue which can cause infection is actually been removed already. Till that time, we can go for some form of external fixation, and usually the best way is to manage the fracture with external fixation till the wound is good enough for internal fixation. Then look at complex injuries. Complex injury means maybe associated injuries. There could be associated femoral shaft fracture, there could be open fracture with femoral artery injury, there could be comminuted shaft fracture with polytrauma, associated tibial fracture, or sort of pelvic acetabular fractures. These are all actually complex injuries. Complex injuries also means femoral artery injury associated with femoral shaft injury. This is Castillo type 3C injury. The first and foremost is to create a shunt and stabilize the fracture by external fixator. Once you've done the external fixation, we can go out for carry out the definitive vascular repair. And once the vascular repair is stored, then comes the then comes the time to worry about the actual soft tissue coverage. Then we can think of the different debridement procedure in necrotic. The tissue should be removed, and once the bed is prepared for some form of graft or a flap, then later on we can think of the internal fixation of the femur. Now, continuing with the complex injuries, there could be associated injuries of ACL, PCL injuries. Knee ligaments may be torn, especially in distal 1/3 of injuries as well. Or there could be fractures which may be associated with the knee as well. That is like distal 1/3 femur fracture associated with proximal 1/3 tibial fracture. This is the classical scenario of a floating knee which needs to be fixed urgently, because this may be highly problematic later on because for the patient, because the knee would be highly unstable to walk. Now, some of the different imaging coming to the pathological fractures of femur. Usually pathologically, patients, that depending upon what type of pathology it is, it could be a benign pathology or it could be a malignant pathology. Usually, if there is a malignant tumor, this is most likely present with a lytic lesion, which would be eroding the cortex, and it would be highly painful. The patient will come to you with the history of pain in thigh area, the hip area, and probably there is no antecedent history of trauma. And when you get an X-ray, you sometimes get this kind of a picture that there was a lytic lesion in the subtroch region, which was involving more than half of the cortex. And although the cortex was intact and there was no pathological fracture, but it's about to happen. We have different classifications which is available as well, and we need to look at whether it's a lytic lesion, it's a blastic lesion, what is the size of the lesion, and whether it is present in the upper limb or lower limb or in the subtroch region, and is it a permeating lesion in the subtroch region. That all determines whether we need to prophylactically fix before even if the pathological fracture has developed or not. And if the pathological fracture has developed, the bone has broken out, then you must fix the pathological fracture, along with depending upon whether the biopsy of this lesion is already present or not. For example, if a female with the CA history of CA breast comes to you and there is a pathological fracture of the distal shaft of the femur or even the subtroch region of the femur, then you not only need to fix the fracture, you need to take the biopsy as well. But if there is a diagnosed case with CA breast with metastasis, then probably the best way is to just fix the fracture, because it's most likely the biopsy will come out to be CA breast. Then it could be a benign tumor as well. For example, if it just is the kind of a picture, this is a young child, let's see 7-8-year-old child comes to you with a limp, there is no pain, but actually parents know that he or she has actually started limping for the past few weeks, and you get an X-ray of the hip joint and you get this kind of a lesion which appears to be lytic with narrow zone of transition and a classical ground glass appearance of the fibrous dysplasia of the proximal 1/3 of the femur. Now this is kind of a picture which is usually decrease neck shaft angle, and there is actually developing Shepherd-Cook deformity. Sometimes it may present with a Shepherd-Cook deformity actually as well. Now this is kind of a situation where you need to be review it in a way that whether the lesion is bad enough to produce a fracture or not. If it is likely to produce a fracture, we may need a prophylactic fixation. Otherwise, close observation may be suffice for these kind of issues. Other is that if there is excessive deformity or if it's a complete Shepherd-Cook deformity, then you may need to do the osteotomy and fix it to recreate a normal neck shaft angle of 135 degrees. Now there is a disease called as Paget's disease, in which there is an abnormal function of osteoblast and osteoclast. There may be associated with a shaft of femur fracture in case of the Paget's disease. If you see this femur, it doesn't look very much normal. This is more of a lytic areas over here with increased sclerosis in some areas. Now this is a classical presentation of Paget's disease. Then the bone appears to be in multiple phases of remodeling. There may be a lytic as well as plastic areas with a transverse shaft of fracture, with the atypical fractures which usually do not occur are correlated with the mechanism of history. They may have to be fixed with either interlocking screws or interlocking nail, or it may be fixed with the distal femoral locking plate depending upon where the fracture is present. Now, classification of periprosthetic fractures. Now, periprosthetic nowadays total hip joint replacement is a very common procedure and is regularly carried out in old age individuals who suffer from either avascular necrosis due to non-traumatic or traumatic causes. Then what if usually what happens is rarely you see a hip dislocation, but sometimes patient had an accidental fall. This results in some form of fracture and patient represent, let's say, after 3 years, 5 years, 7 years with a periprosthetic femoral fractures. There is a classification for that if there is associated AG called as greater trough fracture only, but in this the implant is stable, you need to just fix the greater trough. There may be AL type, or in which there is a lesser trough, maybe avulsed from its area, but the implant appears to be stable and you just need to fix this area. This could be this sort of a fracture in which the lower tip of the implant may be involved. Then this sort of situation you need to make sure that implant is stable. If implant is unstable, you need to change the implant with a longer stem prosthesis as well as fix the fracture. Or it could be this sort of a situation in which the fracture is displaced as well as the implant clearly looks unstable. Or you can have this sort of a situation in which you need to re-implant the patient with a femoral prosthesis with a longer stem as well as fix this fracture with a cable and graft, and may require actually an allograft strut or a autograft cortical strut to maintain this sort of a fracture. Or it could be this type of injury in which the implant looks very much stable, but there is a distal 1/3 shaft of the femur which can be easily treated with open rectangular fixation in form of distal femoral locking plate. If it's a periprosthetic femoral fractures, then comes the treatment. Treatment depends upon where is the fracture and whether the implant is stable or not. If implant looks stable, then all you need to do is just treat the fracture with the cables and screws. But if the implant is unstable, then you need to remove the femoral component, take it out and apply a long stem femoral component along with the fixation of the fracture. Like this, the more tapered stem was used, and the fracture was fixed with cable and grafts and screws. And you may have to redo the whole femoral implant as well. Now coming to the early complications of the femoral shaft fractures. This may include the shock. Why? Because almost 1.5 liter of the blood is sometimes lost in the closed femoral shaft fracture. This could be in form of fat embolism and acute respiratory distress syndrome because it's a long bone with a lot of medullary cavity. There may be the fat emboli which may deposited during the fracture into the bloodstream may cause the femoral shaft fracture, or this may be associated with acute respiratory distress syndrome which may be visible later on within the first week after the injury, or thromboembolic phenomena. Patient may be having a thrombus which may be dislodged and eventually may be leading to thromboembolism. Most commonly is actually the infection, usually associated with open femur fractures because there may be higher the grade of gustula injury, the higher the chances of infection as well. Late complications include the delayed union or the non-union. A patient may present, let's say, have interlocking nail done for femur shaft fracture. After 1 year, patient presents with this sort of fracture which is actually not healed, or this patient can present with at 6 months of age, patient can present with a hypertrophic type of a non-union, that the union is actually being delayed despite the adequate fixation and correct fixation done for the femur fracture. Other is the joint stiffness. Usually if retrograde nailing was done, this is usually associated with a lot of knee stiffness, and aggressive physiotherapy may be required to relieve the patient of the symptoms which may be associated with the joint. Then is the malunion. Malunion is when the rotational profile of despite the adequate treatment, especially if the conservative treatment in the form of spica cast was done for the children, although children have very high propensity to actually elongate and they have a very high degree of tolerance as compared to the rotational problems, but this may still result in some form of rotational abnormality which may lead to in-toeing or out-toeing gait and may be problematic for the patient. Then is actually the non-union, or this form of malunion can also occur. As you can appreciate it over here, this multiple nail was done in an adult patient, but despite all this, the nail is actually bent and resulting in a more of a malunited fracture, which is actually not healed properly. Other complications may include refracture and implant failure, and this is also common, especially when then actually the fracture is not united. The nail cannot take all the weight of the body. This is very important because if the fracture would not unite in time, eventually the implant will fail, leading to either the nail breakage or nail bending, or sometimes the screw cutout is also very common as well. Then you may have to require the do some form of shortening as well, which may be associated with treatment, and then later on which may require corticotomy in form of that you have to cut the femur in the half and elongate it accordingly by use some form of external fixator or laser off. In which, so then why it is required, because eventually the union has to be achieved, and once if the union is not achieved, the whatever implant we use, it will eventually fail. Now coming to the femoral shaft fractures in children. Now, as you know, that the femur is bone which can get damaged in children as well. This could be due to falls, there could be trips, there could be child abuse as well, and this is something, as an orthopedic surgeon, we need to be very careful and on the lookout for a child abuse, especially if the femur can fracture in a non-weight bearing child. How can a bone get fractured when the child is not weight bearing or not walking age, is not of the walking age group? So when it comes to the femoral shaft fractures in children, one must be very careful regarding the child abuse, and we need to be on the lookout regarding this problem. Mechanisms, this could be, as told you, as it could be direct violence. For example, it could be road traffic accident, or it could be a child abuse, or it could be due to fall from a height. You children have a high tendency to play, and then something jumping around. They may fall from a considerable height, leading to femoral shaft fracture, or it could be commonly non-accidental injury as well. Now, when it comes to non-accidental injury, it includes child abuse, child battery, as well as problems such as something which is maybe there at the home, which can lead to this kind of an injury. And other is the pathological fractures and disorders, but usually the pathological fractures in children are rare, and it only involves mostly the if associated with carcinomas such as osteo or Ewing sarcoma, may occur with the local bone lesions as well. Now, coming to the treatment. The treatment especially involves only the age group of the patient. The child may be as young as 3 or 4 months old, or it may be as old as 3 or 4 years old. So if it's a child of, let's see, less than 6 months, then there is no other treatment except parabolic harness. Just apply the parabolic harness which is required and just give conservative treatment. But if it is actually depends, if the child is more than 5 years age, then you need to look at whether you go for operative or non-operative. That depends whether the type of injury and whether the physeal opening is there or not. Then what is more important in children is that if it's 6 months to 5 years, then we may have to go for hip spica, or in form of which is also a non-operative treatment option. Then from 5 years till 9 or 10 years, we can go for either flexible intramedullary nails or plate and screw fixation. And usually after 10 or 11, the most important, mostly you have to go for intramedullary nail fixation, like as in adults. Mostly, then if fixation is actually done, is done by the closed method with the minimal incisions and minimal invasive techniques, and then it's usually the nail is removed once the bone is remodeled over 1.5 years ago. Now coming to the traction and cast in children. Mainstay of the treatment of femoral shaft fractures in children is actually non-operative. This includes the spica cast. As I told you, if the age is from 6 months to 5 years, the most important is the spica cast. If less than 6 months, we can go for parabolic harness. Other is external fixation, but usually rarely done because we have rarely open injuries of the femur in case of the children population. Then it is the internal fixation, which is could be in form of flexible intramedullary nail or interlocking intramedullary nails. Usually when it's 5 to 10 years, the best way is to go for flexible nail because the physis is open. But after 10 or 11 years, we can go for interlocking intramedullary nail as well. But if the child is obese and above 49 kgs, then probably flexible intramedullary nail is not a good option. Then we can go for submuscular plating as well. And lastly, cast and bracing is an option as well in the children because usually they have a very excellent chances of remodeling as well. Now coming to the femoral shaft fracture in children, what is the operative treatment? As I told you, the operative treatment mainstay is the flexible titanium nail or flexible intramedullary nail, in which the nail is actually passed in the distal femur in the metaphyseal region, bypassing the epiphysis, and is actually passed to hold it up here in this fashion so that it can hold the fracture up. Other option is if the child is, let's say, 12 years, 13 years of age, when the physis is actually closed or there's very little growth left, we can also go for intramedullary nailing, but instead of going through the piriformis, we can go through the greater trochanteric entry nail. Then if, for example, the child is around 5 to 10 years in between age and physis is open, but still the problem is that the child is obese, then we can also go for this form of plate and screw fixation as well, or external fixation if that's an open fracture, especially it's a Gustilo grade 3B or 3C injury. Now coming to the complications in the femoral shaft fractures, as like adults, they have high chances to go into malunion or the shortening. Now what is important over here is to understand that knee injuries have a very high chances of developing shortening. In the distal femoral area, there is almost 9 to 10 mm of growth per year. And in the proximal tibial physis, there is almost 5 to 6 mm growth per year, which actually means there is almost 1.5 centimeter growth at the knee area physis. So if there is an injury which damages the distal femoral and proximal tibial physis, this can means that there is almost lag of 1.5 centimeter growth per year. For example, this child suffered that injury, let's say around 8 years. This probably would have a growth potential up till 14 years. So if in 6 years, this child will eventually develop almost 9 centimeter of injury. It can in shortening. So that is a huge amount of a problem. So this is where we need to be very careful, especially when the injuries are occurring around the knee joint, because this can produce shortening, and this could be sometimes very massive amount of shortening, which would later on will be difficult to correct, especially in the case of children. So whenever we have a physeal injuries or the injuries around in the children, we need to be on the lookout for shortening as well. Now coming to the supracondylar fractures of the femur. As I told you, shaft can be divided into the proximal 1/3, middle 1/3, and distal 1/3. Distal 1/3 is actually above the level of condyles. That's why the fractures of distal 1/3 is termed as supracondylar fractures. Now, mechanism and pathological anatomy means this could be secondary to RTA, this could be secondary to fall, or it could be direct hit over the knee joint. AO classification is there, as well as the different type of classifications are available. Usually if the fracture is in the metaphyseal region, it is termed as type A, further subdivided into A1, 2 or 3. And according to the AO, as this is the distal bone of the part of the femur, so it becomes 3.3.A1, 2 or 3. If it's involving one of the condyles, either the medial lateral, it becomes B. Depending on the type of combination which is present, it becomes B1, 2 or 3. And then if it's involving the metaphysis as well as the epiphyseal area or both the condyles, it becomes type 3C injury. C injury can be further subdivided into type 1, 2, 3 depending upon whether the combination is in the articular surface or it's in the supracondylar area. Now coming to the term called as Hoffa fractures. Now if you see this X-ray on the lateral view, you do not appreciate any fracture, because in this he is viewing an anterior posterior plane, that is the sagittal plane. But if you get a CT scan, especially the coronal plane of the same patient, this is what you get, is that there is a coronal plane fracture, which is actually a mediolateral fracture of the condyles involving this is termed as Hoffa fractures, especially in the children. And this Hoffa fractures type of type B injuries, which need to be looked at, especially it's called 3.3.B2 injuries mostly. Now coming to the clinical features. The clinical features of supracondylar fractures include fracture at the supracondylar level, such as especially this will result in massive swelling in and around the knee and just above the knee as well. This could lead to hemarthrosis. The patient may not be able to bear weight on it. There may be associated history of RTA or fall or direct blow to the knee. And then above all, it would be the painful movement, or the movement may be grossly limited, and which would eventually result in a lot of pain during the movement. Now coming to the imaging. Once we get the image, we usually get an X-rays of knee joint. So this is important. You need to still get the one joint above and one joint below, because it is involving the femur. We need to be sure that there is no associated hip fractures, such as femoral neck or shaft fractures in this case as well. Then you need to be sure that it's not a floating knee. And we can also go for X-rays and CT as well. Sometimes CT is required because there is suspicion of Hoffa fracture, and usually it's not visible on APR lateral view. Now coming to the non-operative treatment. Non-operative treatment is the initial treatment in the case of supracondylar fractures, which may include the Thomas splint, which can be temporarily placed till the definitive treatment is done, or the knee can be temporarily placed in form of a cast or a brace, so the patient is immobilized and made pain-free. And once the swelling settles down and all the things settle down, we can go for some of definitive operative fixation. Although vertical traction is an option, but rarely utilized, and usually the skeletal traction in form of a pin being passed through the tibia is more than enough. Coming to the surgery of supracondylar fractures. Initially, the supracondylar fractures were mainly treated by the implants such as DCS or the locking plates. But now we can treat it with K-wires, with screws, with even the implants such as DCS, or even the locking plates such as distal femoral locking plates. One option is K-wiring. For example, if a child comes to you with this sort of a type 4 injury, then because physis is open, the best option is K-wiring. Or we can pass the screws as well, but if it's a child, usually only, because in case of adults sometimes the screws are not enough and they require a proper placement, because later on they have to weight bear on that implant. Other option is like condylar screw or plate, which can be used in case of adults. The screw is passed at the 90-degree, and there is a plate which is attached to this condylar screw, which is called a dynamic condylar screw, or DCS, which is an option as well. Nowadays, we have moved from DCS, which is, you can see it over here. Condylar screw is going through the condyles, and there is a plate which is actually attaching, applying the lag screws as well as through the plate as well. Now the option we have moved towards the locking plates are called as distal femoral locking plates, like this. They have structural, anatomical structure. The screws, these are the locking screws which are going through the condyles, and these are the non-locking screws which are going through the shaft as well. And why they are actually applied? Because these non-locking screws actually produce some form of compression, while these locking screws actually do not compress the fracture, so this does not result in loss of height of the fracture, and they can be later on weight bearing can be done as well. Now coming to the surgery, further different images of the supracondylar fractures. Sometimes this may be associated with problems such as you may have to go for periprosthetic associated fractures, with the TKR may be required as well, like in this situation. But usually for supracondylar fractures, rarely the TKR is the first choice as well. But the patient who already had TKR and now have suffered from periprosthetic type of a fracture, they may have to undergo a revision TKR in this situation. Now coming to the complications. This may include the arterial damage, such as the damage to the femoral artery, which is just passing through the Hunter's canal, are joint stiffness, especially involving the knee, and then may be associated with a malunion or non-union of the supracondylar fracture, and which may require revision, open adduction, tunnel fixation with bone grafting. Now there's an entity called as fracture separation distal femoral epiphysis. Now this is very common in the case of children, especially the children who are suffered through the knee injuries, and which may be why it is important, because the most important, almost 9 to 10 mm, almost 1 centimeter of growth occurs at distal femoral epiphysis. So if this gets disrupted, this will eventually be highly damaging to produce an LLD. And let's say if the child gets this kind of a physeal injury at the age of 6 or 8 years, this may eventually result in 6 to 8 centimeter of LLD at teenage. So there are different types. There is Salter-Harris classification for this. Salter-Harris type 1 is when the physis is there is injury through and through the physis. This is how it looks like. When the type 2 is when the physeal fracture actually goes into the metaphysis. This becomes type 2, and when it goes into the epiphysis, it becomes type 3. Now if you see it over here, the smooth K wires can only be passed through the physis because they do not damage the physis. Whenever we are passing screws, we have to make it sure that we do not pass the screws through the physis because they're going to be damaging it. Either you pass it like this or you pass it like this. And if you get a type 4 injury in which there is epiphysis as well as going all the way into the metaphysis, then you spare the physis and pass 1 or 2 screws into the metaphysis and 1 or 2 screws into the epiphysis. But you do not cross the physis with the screw because that will further damage the physis, which is already damaged. Imaging, if you see it over here, you can appreciate Salter-Harris type 2 injury in which the physis is damaged and fracture is going all the way up into the metaphysis. This would require probably a large fragment, so would require 2 screws parallel to each other for fixation. Or it could be this type of injury as well, in which there is definitely injury to the metaphysis, but is a very small fragment and which may be held up in form of K wires as well. Now coming to the clinical features, usually child would be limping, he would complain of swollen knee. There would be history of some form of injury as well. There is always almost injury associated fall or history of RTA. Then there is palpation. What is important is that due to some sort of excessive swelling, there may be some form of developing compartment syndrome which would compress the popliteal artery. So one must go for neurological examination and neurovascular status as for the patient, whether it's intact or not. And there may be associated popliteal artery obstruction. This may be due to the excessive swelling which may be occurring at the knee joint. This may compress the popliteal artery, eventually leading some form of compartment syndrome. How to fix these fractures? For example, if you have this sort of an injury in which there is a Salter-Harris type 3 injury, you need to have pass 2 screws which are parallel to the physis, not going through the physis, and just making sure that they're fixed in this fashion. Or if you want to go through the physis to make it stable, we have to go for smooth K wires. If you can appreciate these K wires smooth, so they are going through the physis. But we do not pass screws through the physis because that is going to damage the physis more. Further, what else can be done is in form of we can also go for some form of casting as well. Casting is done only if it's an undisplaced fracture and it's only Salter-Harris type 1 injury only, in which there is less chances of physeal separation and decreased angulation as well. What we need to make it sure is that no associated complications. Complications may be included such as vascular injury, especially the injury to the popliteal artery, or it could be the physeal arrest. Why the physeal arrest is important? Because it will eventually develop 2 problems. One is limb length discrepancy, especially if it's Salter-Harris type 5 or 6 injury or 1 type injury in which there's complete separation. This will eventually damage the whole of the physis and lead to LLD. Or it could be injury to either, for example, if this sort of injury is occurring on the physis on this side. Now if this is the problem over here, this physis will not grow and this will continue to grow. And if this is a lateral side, this would result in some form of genu-varum. Or if the medial side is growing and lateral is not growing, this would result in some form of genu-valgum. So this can produce either the rotational deformity or eventually limb length discrepancy. So Pfizer arrest in children is very problematic and may be require a lot of treatment in form of either shoe raise, epiphysiodesis, or contralateral shortening or lengthening of the ipsilateral limb as well. So for more videos and more lectures on orthopedics, keep watching sqadia.com.